today it is my great pleasure to welcome back to Empowered Dr. Ted Steele. So Ted and I had a really interesting chat about all manner of things, but in particular the panspermia hypothesis of evolution a couple of weeks ago. If you missed out on that one, do go back and watch it. But I'm welcoming for the first time today Dr. Paul, I should have got your credentials. Paul, I'm assuming you are Dr. Paul Goldwater. Am I right or wrong?
That's me, yes.
Or Professor.
Professor Paul Goldwater. And you are a professor at Adelaide Medical School at Adelaide University, right?
Correct, yes.
Excellent. Okay, and the reason for...
I'm actually retired from clinical practice.
Right.
I'm a senior researcher
Okay.
acting through the school, the medical school, yeah.
And that may be the answer to one of the questions that I had, but we'll get to that shortly. Now, the reason for me getting you both on today is you are exactly one half of the authorship team of a new paper that's been published, and it's called Sudden Infant Death Syndrome in the Context of the Future of Vaccination and the Question of Systemic or Mucosal Immunity. And I guess putting sudden infant death syndrome and vaccines or vaccination in the same title is probably enough to get you thrown out of a lot of rooms in polite society. So I am going to pop the paper up on screen, but tell me, how did this paper come together? Whose crazy idea was this? Who's going to take responsibility?
It was initially Ted's idea. He approached me as a purported expert in SIDS. I've been working on SIDS for 35 years plus. As part of my professional job as an infectious diseases physician at the Women's and Children's Hospital in Adelaide. And that's been my main sphere of interest. But I've been involved in many infection-based ideas and interests. I've done quite a bit of immunization work. I've done studies with hepatitis B virus vaccination. I developed a low-dose immunization when I was in New Zealand to try and cut down the cost of protecting the Maori population in the Bay of Plenty in the North Island of New Zealand, where hepatitis B was endemic. And so I've had a pretty broad sort of background.
And when you say you were working in the infectious diseases arena, and you had an interest in SIDS, I don't know that many people put those two together. The idea that SIDS, sudden infant death syndrome, has some relationship to infection, but you've actually developed a hypothesis, the infection hypothesis of SIDS.
Yes, I'm not the only one who has been working in this sphere. Caroline Blackwell, who was based at Newcastle University in New South Wales, she and an English professor in pathology, James, oh gosh, I'm blocking his name. That's the problem with age, I'm afraid.
There's too much in the filing cabinet, Paul. It takes a while to find the right folder.
So we three have been sort of pushing this pretty well-based idea for over 30 years. And
the idea that sudden infant death syndrome has some connection to infection.
Incredibly close relationship to infection, particularly respiratory viral infection. And the core of the hypothesis that respiratory viruses, in combination with bacterial toxins, particularly Staphylococcus aureus toxins, can lead to sudden infant death syndrome. The original work showed that bacterial toxins were found in about 50% of SIDS babies' tissues. And that work has been largely ignored. And that was discovered in the 70s.
How interesting.
And the effect of smoke on infection. Smoke exacerbates bacterial and viral infections.
Sure. Yep. Yeah, and so instead of a focus on this, we had the whole back to sleep campaign. You know, put your baby on its back to go to sleep. Don't let it sleep on its tummy. Yeah. Well,
now, that back to sleep work has been examined in a proper case control study. Randomized control study, and it's all based on sort of pretty loose epidemiological evidence. What is actually, if you look at the infection rates, for instance, respiratory syncytial virus infections and other respiratory infections, they parallel the decline in SIDS. So there's a very strong relationship between SIDS and respiratory infections. SIDS decline in exactly the same way as respiratory viral infections did around the world. And this is well established, but it's all totally ignored. The list of risk factors that have a relationship to infection is enormous. There's probably about 30 or 40 risk factors that have a direct or indirect relationship to infection. And it seems to be staring everyone in the face, but they can't see it.
I think what you're raising, Paul, I'm sure you're aware of the germ versus terrain argument, which gets very passionate, and you get people who insist that there is no such thing as viruses, germs don't exist, it's all terrain, and then you get people arguing that it's all germ. And I think what you're saying is, look, folks, it's both. There's bugs over here, and there's risk factors, environmental factors, genetic factors, which I think we'll get to as we dig into this paper. There's factors like, in the case of the baby, was the baby born through C-section, or did the baby come down through the vaginal canal? Is the baby being breastfed? Is the baby exposed to smoke from a smoking parent, aside from smoke, for instance? Yeah. Okay. So, right. So we've got this connection, as you explained, that has been largely ignored for strange reasons, between infection, particularly respiratory infection, and SIDS. How does that connect to vaccines, to the childhood vaccination schedule? And Ted, you might want to jump in here, if this is more your bag.
I'll just give you one inkling. Vaccines are a pseudo-infection.
Okay.
That sort of sums it up. And Ted, you can take it from there.
Take it away, Ted.
Very lucid description of Paul's main work and findings over the last 35 years or so. And I had not known Paul Goldwater until about 3 or 4 months ago, when my academia.edu website alerted me to the fact Dr. or Professor Paul Goldwater had published a review on SIDS, and it might be related to some of the stuff I've been sort of banging on about, which I posted up to my site. And I contacted him. I tracked him down, contacted him, and sure enough, because when I read his articles, I could see they were directly relevant to everything that was rattling around in my head, particularly with Walter Brzezinski and my other co-workers, Dr. Robin Linley, when we were trying to come to grips with the COVID, crisis, particularly in old, elderly, comorbid people, the ones that really died of a respiratory tract infection. And there it was clear that and I said this to Paul in my opening sort of emails with him, that the innate and particularly the innate immune response, the immediate response in the first 24 hours, had pretty well collapsed in these elderly patients that went on to die from the COVID. So I thought, well, everything he says makes perfect sense to me, that, you've got an aberrant immune response going on, probably in these infants, these babies. And so that's how it evolved. It matured from there and to a first paper where we outlined some of that in summary, I've just said. But this last paper, I think, is probably even more important than the first paper, in the sense that it outlines all the mechanistic reasons behind why vaccines can be both helpful and dangerous. That's all.
Yeah, so I've just popped the paper up so that people can take a look at it. And what I'd like you both to dig into is systemic and mucosal immunity. And there is I don't think I can highlight this, unfortunately, on StreamYard, but folks, if you take a look in the abstract and go to the fourth full line from the bottom, there's the phrase, the Th1-based mucosal immune system and the Th2-based systemic immune system. And that differentiation between these two, if you like, arms of the immune system is really pivotal to understanding this whole topic. So Ted, if you could jump in and explain, what is the mucosal immune system? We've discussed that in our previous talk. What is the mucosal immune system? How is it different to the systemic immune system? And if you could further explain, what is Th1 or T helper 1 and Th2, and how do they relate?
Well, look, let me start with Th1 versus Th2 first, and very briefly summarize them. The Th1 response, which is and Th2 are the typical maturation of responses that go on in the blood response, the systemic response to infection. And the Th1 is associated with the pro-inflammatory, that is, inflammatory, curative response. Oh, sorry, there's a bit of that's not my end, but and anyway, so it is a good summation term for the curative, protective immune response. Okay, whereas the Th2 response is the response that we typically see when we can detect the antibodies in the blood, and things are maturing through various stages of infection. If it's a bloodborne infection, and largely what we point out in the paper is that the whole approach to vaccination over the last 50 years has ignored the fact that Th2 responses are an indicator of a matured immune response that is basically ineffective in many cases. It's an indicator of prior infection and immune response, but the actual response itself is anti-inflammatory, and the horse has already bolted, and then they shut the gate. So the reason we had to point that out is that I was aware of that, particularly with all of the work that Professor Peter Brecher has done over 50, 60 years at the University of Saskatchewan. And he's an old colleague of mine, and we did our postdocs together at the John Curtin School of Medical Research, and so I knew how important his work was. And then things started to gel with my interaction with Paul. And then after our first paper was published, I started to look, there is a big role here for all the insights that Peter's gleaned over the years. So that's why we decided to lead off with that difference first and contrast it with the mucosal immune system, which is first-line defence at all the external surfaces, the eyes, the nose, the mouth, respiratory tract, the lungs, gastrointestinal tract, the genitourinary tract, and in a lactating mammary gland. So, which supplies immune colostrum in many ways to the baby.
Yes, the baby's very first food. So before you go on, Ted, let me just very, very quickly summarize. So what you're saying is that the Th1 response is the body's natural response to infection, where it goes out kind of all guns blazing to target the bacteria or the viral infected cells or whatever. Yes. And so that Th1 response is there's a pathogen in here, let's go get it. And then as that is kind of subsiding, you get the rise of the Th2 response, and it's the Th2 response that gives you lasting immunity. And then this is this is the immunological memory, if you like, where if the immune system encounters that pathogen again, it says, I know what to do, I can ramp up immediately. Okay, so that's
the mucosal immune response is different.
Yes. Yes. Go on. Let's jump into mucosal. Thanks.
Yeah. Well, that has its own set of rules, as it's turning out, and there is an interface, an interaction, and communication between the mucosal system and the systemic system, but they can effectively operate independently in an operational sense, because the mucosal system has got to try and dispose of everything coming in large numbers, new antigens, infections all the time through the nose, the eyes, the mouth, and it's got to be able to react immediately through its innate immune response, and then if there's been some sustained infection, to develop a secretory IgA response, which is an adaptive response, but which will have memory about it. And that's why we had to deal with the two. And it's been clear to me ever since COVID, because it was COVID that opened my eyes to all this, that the failure of the shot in the arm vaccine, however safe or effective that might be in inducing Th2 immunity in the blood, let's say, that can't initiate the initial protection sequence against disease in the coming in by the nose, mouth, the eyes. So
the shot in the arm induces antibodies in the blood, but the infection is contracted via the mucosa. Exactly. So those antibodies in the blood are not going to magically appear in your nose and allow you to neutralize the virus which you're inhaling. Paul, you wanted to add something?
Yeah. Can I just say, you're targeting a pathogen, COVID or respiratory syncytial virus, pneumococcus. Well, let's talk about respiratory viruses first. The majority of them don't actually enter the bloodstream. You don't get viremia with COVID, with influenza, with parainfluenza, with RSV. So why would you develop a vaccine that produces IgG in the bloodstream when the virus is not there? Why would you target a pathogen that never enters the bloodstream?
And it seems that no less an authority than Dr. Anthony Fauci agrees with you, because this table is from the paper that Fauci published along with several of his colleagues in, it says right here, 2023, differentiating between infections that do cause viremia, so marked viremia, in other words, virus actually in the bloodstream. And so you can see here we have measles, mumps, rubella, smallpox, varicella zoster, was chickenpox. So all of these infections do cause the appearance of viruses in the bloodstream. But look at the ones that don't. Endemic coronaviruses, influenza virus, parainfluenza, RSV, and SARS-CoV-2. So none of these cause viremia.
Correct. So reducing antibodies in the blood is a waste of time.
Yes.
Oh, by the way, that table is informative, because that's why we republished it, because it's on open access. But there are some misleading things about the table. For example, when they, in the bottom right-hand corner, they talk about non-replicating virus for COVID-19. Well, by that they mean the mRNA. Well, that is a super spike antigen replicating thing, which is totally unnatural. So that's a bit misleading. But some of the other things for that group that you just mentioned, the respiratory tract viruses, if you like, there's a number of misleading statements when they talk about the no list. They should be saying we don't know. We haven't really explored this. So there is some misleading things in that table, which I didn't really feel that we should point them out in the paper, because that would it's just the main point that the paper makes. Go on.
The point is that is that there is widespread acknowledgement that developing vaccines that are a shot in the arm for infections that are contracted through the respiratory mucosa is nonsensical. It actually doesn't make sense at that basic level. And Fauci knew this while spruiking for the COVID vaccine and pushing the flu vaccines and still doing that to this day. So I know you can't speculate on what's going on in another human being's brain, but boy.
Yeah, I'm absolutely certain he knew. He's been an immunologist for 50 or so years, like I have been. He must have known it. So that's all I can say.
He must have known. Yeah. Well, I guess we'll leave it there. So we now understand the Th1 response, the Th2 response, the difference between the mucosal immune system and the systemic immune system. So let's turn now to the childhood vaccination schedule and its possible, putative, speculated upon relationship with sudden infant death syndrome.
Well,
Who'd like to take this?
I'll just say what Paul said, the infection hypothesis and vaccination are intimately linked. So if there's any aberrant immune response in a child induced by vaccination episodes, then that child is going to be vulnerable. That, I think, in a nutshell, sums up the possible link.
Yeah. What evidence is there for such a link?
Well, there's the work of Goldman and Miller, which we describe in the paper. They describe the vaccine, the number of cases of SIDS described in the vaccine adverse event register data. And up to 51% of those vaccine adverse events are SIDS cases. And they looked at the infant mortality rates in terms of the number of vaccines given. And there seems to be, well, they've demonstrated a dose effect. The more vaccines given, the higher the mortality rates. And
yes. Well, that's down in the discussion section here in the first column. And so we drew attention to the strong positive correlation, linear regression between a number of, I've got a big thing sitting right in the middle of my screen there. I can't read this, but yeah. So there's a strong positive correlation between the number of vaccine doses, and we'll tease apart that particular phrase in a moment, I think. So the number of vaccine doses and the essentially the incidence of SIDS. And I believe also in the Miller and Goldman papers, they talked more generally about infant mortality and the correlation between the number of vaccine doses on the schedule and infant mortality rates in high-income countries.
Yeah.
Look, I will just say that we did republish that linear regression, the strong correlation between doses and incidence of sudden death or incidence of unexplained sudden death syndrome in our first paper. We actually republished that key finding, but it's been the same group as that Paul mentioned, Miller and Goldman. They actually published a follow-up analysis of global, but of 46 advanced Western countries, the advanced health systems, and they just confirmed their survey from 2009. Nice linear correlation. So. It's well established statistically that there is this, and of course Paul points out when they delve into the adverse event data, there's a strong correlation between the shots and probably more shots and then sudden deaths, a week or two later.
Yes.
So,
yes.
So earlier than that. So the point is that there is a strong indication that the infection hypothesis has been is correct, that there's been aberrant immune response in the baby to just a passing by infection, a cold, but the cold gets traction very quickly because its system's not reacting in the first 24 hours. The innate immune system, and the virus just replicates and overwhelms the baby, and the baby's dead within 48 hours. That's much like the COVID patients. That's why I was attracted to what Paul was publishing. I could see the similarity between vulnerable early COVID patients and babies that were going down with SIDS. Yeah.
On that subject, Ted, could you briefly discuss what is the difference between the infant immune system, say the infant, the immune system of a newborn up to 6 months, up to 12 months of age? What is the difference between the infant immune system and the immune system of the mature adult or even the older child?
Well, look, Paul would follow me up. I'll just give it the sketch because he knows better, much more than I do. He's been studying this for so many years. But the literature shows you that the infant immune system is still developing up to about 6 months. That's why the mother plays a critical role with protective immunity from the colostrum, particularly with antibodies from infection experience that the mother has, and it's passing it on to the baby, and that's getting into the respiratory gastrointestinal tract. So therefore, it's clear that that can be very effective in suppressing all infections. And of course, as Paul points out, there are also other evidence and many other factors going over in the colostrum, including cells and other sort of stuff. So the role of the mother in that first 6 months is crucial. And of course, there's been a move away. This is one of the things that alarmed us when we drafted our first paper. There's been a move away in the last 40 years to taking babies off the breast early and putting them on formula milks. So that's been one. And the breast baby organisations, from the mothers and the women that run those, they're absolutely categorical about it, that the longer you can keep the baby on the breast, the happier and safer the baby is. So, those sort of factors. But Paul's got more knowledge on that developmental phase than I have, because I'm just going, but we both, he knows that sort of literature in real time with baby development. Yeah, Paul.
Yeah. Paul, actually, do you know what? Could you take it back even a step further? What is happening when the baby is in utero? How is the baby protected against infection in utero? And then let's take it through birth, and then say the first 6 months of life.
Yeah, well, the placenta does a big job in preventing infection, but the maternal immune system is vital. Of course, some viruses such as rubella can cross the placenta early on and cause havoc to the fetus. But it's the key protective elements are transplacental antibody from the mother and colostrum at birth. Those are the essentials for adequate protection. Now,
sorry, Paul. Transplacental antibodies. So again, these are antibodies circulating in the mother's bloodstream that cross the placenta and are able to provide immunity to the baby.
Yeah.
Is there a difference between antibodies that are generated when the mother has an exposure to infection? The mother has had measles, the mother has had rubella, the mother has had the flu, and had it recovered from the infection, has durable immunity. Is there a difference between the antibodies, the transplacental antibodies generated by natural infection in the mother, and vaccine-induced antibodies? So, for example, the mother has received a vaccine against rubella or flu or COVID for that matter.
There is actually. Vaccines will generally only provide IgG to transfer, But some, they have shown that some vaccines given during pregnancy will provide IgA as well, which is quite interesting, and it also provides that the infant that additional protection. But it's IgG, which is the usual protective antibody that's transferred, and but it's critical in terms of the age of the infant at birth, the gestational period, because there's very little antibody transferred before 28 weeks. And you've got to get to 34 weeks before you will get any protection, any real measurable protection.
So these babies who were born extremely mature haven't received this protection from transplacenta.
That's why they're so vulnerable to infection. Yeah. And it's interesting that twins, because most of them are born prematurely, because they just can't fit. They can't get the whole hog usually, and the natural determined term for a twin is 37 weeks, not 40. And but most twins are born very prematurely, and guess what? They have a much higher incidence of infection, and guess what again? They have double the rate of SIDS than singletons.
Oh, that is so interesting. I had never heard that before. I'm just thinking about my brother and sister who are twins and who were adopted and therefore not breastfed, and their trajectory of allergic and infectious illnesses throughout early childhood. Yeah, what you've said just makes a lot of sense. Okay.
When you look at twins in relation to vaccines, they have a much higher mortality rate generally as well.
Is this something that shows up in the VAERS data, or has it been published elsewhere?
Unfortunately, the VAERS data does not distinguish between twins and singletons, so we don't know. But there will be twins in there for sure.
I imagine you heard about a fairly recent case where triplets received a series of vaccinations on the same day, and then all three of these infants died within, I think, about 12 hours of each other. The most unbelievably tragic case. So, I'm imagining what you've just said about twins applies even more so to triplets.
I'm actually in the process of proofreading a paper I've just had accepted on twins, SIDS and infection. And I'll send that to you in proof form so you can get a handle
on
this whole thing. I think twins are an exemplar of the whole issue with infection, vaccination, and SIDS.
Yes, agree. That's very interesting, Paul.
Marvelous. Well, not marvelous for the people involved, but yeah, thank you for that explanation. So let's now put this into concrete form. Okay, so parents take their 2-month-old baby along for their for their checkup and their 2-month vaccine visit, at which time they will be receiving a hexavalent vaccine, I believe. It's a DPT with injected polio and what else is in there, Paul? Jog my memory. There's 6 antigens.
What else is in there? Well, they get Hep B at birth.
Yes, Hep B at birth. I think it's the Hep B. I think there's a Hep B in that hexavalent at 2 months.
Again. Yeah. There's the hexavalent, which is Hep. God.
I'm just pulling it up right now. I should have got this up before. Sorry, I put you on the spot there. Okay, let's see now. Here it is. So at 2 months of age, the infant will receive diphtheria, tetanus, pertussis, hepatitis B, polio, Haemophilus influenza type B or Hib, along with rotavirus, pneumococcal, and if this is an Aboriginal or Torres Strait Islander child, they will also receive meningococcal B. So that's 1, 2, 3, 4, 5, 6, 7, 8 antigens at the one exposure, 2 months of age, or 9 if this is an Aboriginal child.
Those numbers, yeah.
They'll receive 66 antigen targets within the first year of life.
So what happens to a 2-month-old baby with this immature immune system when they're exposed to this load? And I'll come back to the adjuvant question in a moment, but let's just stick with the antigens. Okay, what's actually happening in the system of a baby exposed to this many antigens in one go? And actually, sorry, I'll preface that question by saying, would this happen in nature?
Only to a small extent. We know that you can get 3, maybe 4 co-infections with respiratory viruses, and a bacterial infection thrown in as well. That's about the limit in nature. So it's not natural for us to get so many at one time.
Yeah, but it's all right, Paul, because they put them in different arms. Seriously, I've actually heard this as like a rationale for, well, you know, is it natural to give the baby exposure to so many at once? Well, it's all right. You just stick like 2 in this arm and 2 in that arm and 2 in each leg, and you're good. What's wrong with that? I'll laugh.
Yeah, the only way to describe it is it's hyperimmunisation.
Yeah, and so. What's actually happening in the baby's body, in their bloodstream, in their liver? What is going on physiologically when a baby has this many antigens at once?
Yeah, I don't know really.
We don't know exactly.
That's the problem. We don't know.
But we could just, because most of the studies, as Paul keeps reminding us, and Reg Gorzinski or other, have all been done in adult. All these studies, the safety and efficacy have been done in adult human beings or late, teenagers. So, but it's hyperimmunisation, but it's super hyperimmunisation.
We know what happens in animals.
Yes.
Yeah.
Well, tell us about that, Paul. What happens in animals who are exposed to multiple antigens at the same time?
They can get immunotoxicity, and Ted can tell you much more about that.
Well, the experimental scientist doesn't worry too much about the animal, unfortunately, but you can get all sorts of crazy immune responses going on in animals when you soup them up. Hyperimmunisation, that's all I can say. The cytokine levels, all of the different hormonal-like molecules that communicate with other lymphocytes and other parts of the immune system, they would be being released in a totally uncontrolled manner. And in a baby, where that would be developing, that capacity to respond would be developing. I can only just imagine. I'm using my imagination now. I can just imagine the cytokine storms in the baby. Now, we know from other studies, often unconnected to immunology, but they are connected through Edward Bullimore, who's been a major researcher on the role of systemic cytokines getting across the blood-brain barrier and affecting brain. development, particularly depression in people suffering from, systemic infections or systemic hyperstimulation, are very depressed. And so he was attracted to that. But you can imagine, as an area to study, but you can imagine what that might be doing to the baby. We're talking about brain health, early developmental brain health. So it's a totally uncontrolled storm of cytokines from the body, it seems to me, into the baby's brain and central nervous system. So just on first principle grounds, I'd be alarmed by that, We'd be very, very careful, that's all.
And if you look at the blood and the CSF of babies that have died of SIDS, they have elevated pro-inflammatory cytokines. They're all there. Evidence is there.
Yes, so CSF being cerebrospinal fluid, so the fluid that actually bathes the brain, which is kind of filtered from the blood, I suppose. So what you're saying is that these inflammatory chemicals that are part of the immune response that are generated when the baby is exposed to these multiple antigens, among other things, can cross the blood-brain barrier. And so when you hear stories from parents, as I have personally many times, as well as seeing plenty of video testimonies of these parents, where they say, my child was developing normally, he or she was meeting their milestones, they were making eye contact, they were babbling, they'd in many cases acquired speech, they went in for their shots, and then that night they had an extremely high fever and they went all floppy. Or the high-pitched screaming, that's the other one. They had this high-pitched screaming, inconsolable high-pitched screaming that went on and on and on for hours. And then after that, my baby was no longer my baby. Lost speech, lost eye contact, developed, repetitive movements, the hand flapping, the toe walking, all this sort of thing. So I gather what you're saying, Paul, is these parents might be crazy.
No, they're not crazy. No, they're observing a true phenomenon, I think. Yeah.
Yeah. I recall also that Archie Kalakarinos in his book Every Second Child. So he recounted. So every second child in the title refers to the fact that every 1 out of 2 Aboriginal babies was dying. Their infant mortality rate was 50% in these poor communities. Colorenabri, I think, was where he was posted, and so every second Aboriginal child died until he was doing an autopsy on one of these unfortunate babies who had died. And he found that the liver was grossly enlarged and covered in petechiae, microhemorrhages. And he inferred that there was an acute drop in vitamin C levels. And he began administering vitamin C to these kids along with their shots, and got that infant mortality rate right down. And then, as I recall, the story was he went away on holidays or to a conference or whatnot and employed a locum and gave the locum strict instructions that he was to administer vitamin C, IV vitamin C, along with the vaccines, and the locum blew him off. And then the kids promptly started dying again, and this locum was just about lynched. He was nearly run out of time. Luckily, Archie got back in time and, managed to save the kids again. So this cytokine storm, it's it's not only affecting the brain and the nervous system. There are other organs affected as well. And so bringing this back to the issue of SIDS, sudden infant death syndrome, what is the relationship between these elevated cytokine levels and other immune responses to multiple antigen exposure and SIDS?
Well, it hasn't been explored, not properly. The two haven't been put together in proper investigation.
Yeah, I I first came across controversy, I suppose, in relation to vaccines when I started attending conferences that were organised by, let's just say, some vaccine sceptical parents and practitioners. And one of the frequent speakers at these conferences was Vera Scheibner. Do you know of Vera?
Yes, I'm aware of her. Yeah.
I don't.
So Vera and her partner had developed what they call the Cot Watch monitor. So it was an underlay that the parents could put underneath their sleeping baby, and it would monitor interruptions to their breathing rhythm. And what they noticed was that there would be series of, and then the thing would actually sound off an alarm if the baby went into respiratory distress, so the parents could go check on the baby. And they started noticing that there would be these episodes that would go for a couple of days of just bouts of this distressed breathing. And then when they went back to the parents to say, hey, what's going on? We're seeing all these disturbances in breathing. Was there anything unusual that happened? It started to emerge. That was when they took the child for vaccines. And Vera and Leif came into this field without any thought whatsoever about vaccines. They just thought, okay, we'll develop this Cot Watch monitor and we'll help parents intervene early if their babies go into respiratory distress. And of course, as soon as they made this discovery, their name was mud, and they faced all sorts of persecution and legal, shenanigans, and God only knows what. So, what do you make of that?
Well, it should have been investigated properly, and I don't think she has had an opportunity to publish this in, respected journals. I think she was sort of shouted out of town. She
was. Yeah. She
Yeah.
absolutely was. Which brings me to a question that was on my mind from the time that I first saw your paper. How did you get this published?
Yeah. It's interesting. I was asked by the editor of Medical Research Archives, which is the journal of the European Society of Medicine. I was asked to provide an article because he'd been looking at my work and thought it interesting. And it just happened to coincide with Ted approaching me to do this article with Reg Gorzinski from Canada.
Yes. And what was the peer review process like?
Well, it went through its normal process as far as I'm aware.
Yeah. Okay.
Yeah.
There was quite a bit to correct him, but he also said this is an extremely sensitive topic. I remember that was one of the comments that came up.
Yeah.
No kidding, right? Do you think that this article could have been published before the whole COVID episode?
I don't know.
Probably not.
Yeah, pragmatism kicks in now.
Not in the conservative journal.
Yes, exactly.
No.
Well, what do you think has changed? I mean, I can say what's changed out there in the non-medical world is that parents are asking a lot more questions. What's changed in the academic world, and including the world of academic publishing?
Oh, it's still slow. Sorry to jump in. It's still slow. The change is not as obvious as just you speaking to Paul and myself, that we can see things clearly. No, I think it's still slow.
Yeah,
and go on, Paul.
Yeah, I think the journal we published in is an outlier. It's obviously much more open in their attitude.
Yes.
I don't know what's changed, for that to happen. I don't know what the basis of it is. But for taking us on.
Yeah, I do remember Paul pointing out in his first article that I read, which was brought to my attention. I said, "Well, this man is on the right track as far as I was concerned." And he was making a call to arms and says, "Look, we've got to collaborate outside our own restrictive SIDS discipline of paediatrics." And that's when I thought, yes, that's right, that would be very useful. So that's how our collaboration started. With traditional immunologists like me and Reg, with Paul. And we could see, we'd already gone through COVID, could see the madness going on through COVID with vaccination and not working and all the mistakes that were made. So there was an opportunity here to add information to everything that Paul had done. So you are witnessing, you're interviewing people in the early stages of the academic science community, if you like, now that are publishing. And then, of course, there's all those scientists helping Robert F. Kennedy Jr., and they're very astute statisticians and medical people. And so there is a growing point going on. It might take a few years. It might be, but we certainly know that Robert F. Kennedy Jr. is not making too many friends in the pharmaceutical industry or even in the traditional medical industry.
To put it mildly, yes, to put it very, very mildly. Yeah, that's so interesting. And I just want to pick up on what you said, Ted, there about researchers moving outside their field, because, look, you see this in every domain of not just medicine, but
everyone's in a bubble, right? They don't want to go outside,
This is what we know about SIDS, right? Yeah. And so we're just going to focus on this. And if anyone comes in and says, "I've got a new idea about SIDS," go away. We don't want to hear from you. We already know.
It's an old age dogmatic bubble we all live in, our own little worlds, and we don't want to have any other new ideas infecting that world. Yes, it goes back through the ages. The history of science is populated with all that, and medicine. So yes, there's nothing unusual about that behaviour, but we've got to somehow or other communicate outside our disciplines somehow.
Yeah. I think it is changing slowly. There's a recent paper looking at the metabolomics of SIDS and looking at some specific proteins that relate to the immune response and immunity. And this is by a group in Norway, but also in collaboration with Roger Bayard, who is the designated controller of SIDS information. He wrote the definitive book on SIDS, and he's obviously is taking on some of my ideas.
Okay.
Much to his own chagrin, I think he's been forced to. And
but he's in your medical school, Paul. He's in your medical school, I understand.
What's that? Yes, medical school was me. Yeah. We used to be collaborators, but because I don't know the reason why, but we fell out on philosophical grounds.
Very common.
I see. And what is your relationship with your colleagues like at the university, Paul? You're saying some things that
I never get a comment. It is just greeted with cold silence.
Only silence.
Yeah,
that's extraordinary. So no one will challenge you on your work. No one will say, "Paul, I think you're wrong."
No,
they just ignore it.
That's exactly right. That's been my experience, throughout my career in science. It's dead silence and no reaction.
Yeah.
And in a way they can't, because they have to admit that they're wrong, or they've made either the wrong application or the wrong assumption. So it's a terrible fork in the road for your critic. So they remain silent. Or they're worried about career and whether they're going to get a research funding or get a promotion, so have to remain silent.
Yeah, that's right.
Yes, I noticed that your funding disclosure on this paper was we didn't get none, which doesn't surprise me. So there was no funding for this. You basically all got together and donated your time to produce this paper. What is the future for this kind of what is the future for this kind of work and the research that would be required to take your hypothesis and test it? What is the future for that if you can't get funding?
Well, of course, it's pretty negative, isn't it, if you can't get funding? But let me say, there is some positivity on the horizon. There's work going on in WA, at the University of WA, by Melanie Andrews, who's a young PhD student who's got really good funding to basically explore infection in SIDS.
Okay. That's his start.
I've been sort of a mentor for her to sort of make sure she's asking the right questions.
Yeah.
And vaccines weren't on her list, but they are now.
Okay. We'll see how see whether her funding dries up. Given how tightly the purse strings for that funding are held by various institutions that are really committed to the vaccine schedule as it is, and stuffing a few more in there for good measure. Have you ever thought about alternative models of funding? For example, crowdfunding.
I've thought of it, but look, I'm in my 80th year. It's probably a little late. I think it's time for some younger researcher to take up the cudgels.
Yeah, when I was going with science, we didn't have things called crowdfunding or anything like that, so it never occurred to us to even attempt that. But you did try.
Yeah, I totally get it, and I'm not putting pressure on you guys. I just know that funding, getting funding to pursue your interests is really tough when your area of interest is just so outside the mainstream. And it's not just outside the mainstream. I mean, it poses a major threat to a very powerful industry. An industry that has really, got governments all over the world by the short and curlies, and we've got Moderna setting up manufacturing plants in Brisbane and Melbourne to make more of their wonderful mRNA that worked so well the first time. So I don't know. I really think that alternative models of getting funding need to be explored, and I dare say there are a lot of parents who are really grappling with tough questions about what they should do. I'm having a lot more conversations with my clients who are either expecting a baby or planning pregnancy, and many of them say, look, we just don't want to vaccinate at all. The whole COVID episode just burned us so much. We don't trust doctors. And I mean, look, full disclosure, I didn't vaccinate my kids. I had a look at all the infectious diseases. I had a look at the vaccines, and I thought, there's not a single one of these vaccines where I can really, really confidently state that the benefits outweigh the risks. And in that case, I'm not going to put them through unknown risks. However, having said that, there are many parents who would like some type of alternative to the current vaccine schedule. And I noticed in your paper that one of the ideas that you raised was vaccines that would be administered via the respiratory tract. In other words, presenting the vaccine in a way that, let's just say, mimics the natural infection far more closely. So Either of you jump in. Tell me more about respiratory or mucosal vaccines. Have any been developed? Do they work? Are they safe?
Well, the polio vaccine, the oral polio vaccine, is a prime example. Works through the gut mucosa, induces the right antibody responses, local IgA, and also develops immune memory for circulating IgG to protect the infant, to stop the virus entering the central nervous system. Now, the injected, the killer.
It's also responsible for all the cases of polio in developed countries these days, though, isn't it? Because the virus is transmissible through babies' nappies.
But the killer vaccine doesn't prevent infection. It only stops the virus, once it's entered the bloodstream, from getting to the central nervous system.
Say that again, Paul. That's really important. The kill virus, which is the injected one, doesn't prevent infection.
No.
What does that mean for people who are in contact with the person who's just had that vaccine?
Well, if they're not protected with circulating antibodies, then they will get infected if they're exposed to the wild virus.
Yep.
And there's a 1 in 1,000 chance of getting clinical polio.
Yep. Okay. That's not good. Right. Any other mucosal vaccines that have been developed already and shown their efficacy? There's a flu vaccine, isn't there? Something called flu mist, I think it is.
Yeah, there are a few in development. Nasally applied vaccines. What else? Can't think of any at the moment.
That's about. Well, you probably know more than me, Paul, but that confirms what I've been reading too. So, but what we do is offer alternatives that avoid things like toxicity of adjuvants. But they've got to be safe. We stress they've got to be safe if they're going to go through an inhaler or a spray in the nose. And we mention that because, that's the way the mucosal immune system operates. If you activate one part of the mucosa, it actually can spread the memory to other parts of the mucosal immune system. So it does make a bit of sense, doesn't it? If we go in by a non-harmful route that activated the mucosal immune system, that might be a promising line of work. The reason we argued against the pure oral is there's a real phenomenon called oral tolerance that can develop from antigens going down into the lower bowel. It's probably because they've got so many bombardments down there, they have to damp everything down as much as possible. That's just my gut feeling, if you like. But the nose, that's one way of activating the mucosal immune system and potentially systemically. Because I just want to add one point that was relevant to say a little bit earlier about vaccinating, mothers. If a mother has already had a genuine mucosal infection with a respiratory, virus like COVID or flu or the others, then systemic vaccination can actually recall the memory cells that are trophic, that are that actually like behaving in a mucosal environment. So that probably explains some of the anomalous findings I was finding during COVID as well. But that would be one explanation for why.
Say more about that anomalous findings.
Sorry.
Sorry, I just wanted you to say more about anomalous findings of mothers or women who'd been exposed to COVID had a natural infection.
Yeah, there were two. Well, there was several contradictory findings coming out during COVID that cholesterol antibodies from mothers were appearing. After they'd been vaccinated with the COVID shots, they were producing the necessary antibodies. So they thought, well, that's good. Then there are other findings during COVID where they seem to establish by eliminating getting appropriate control groups, those that had never been exposed to COVID had showed no mucosal immunity on a systemic shot, right? Yeah. But so this, putting it together with all we know about mucosal immunity and the immune system, it just made sense to think. And by the way, the experts, Russell and Mustecki, really summarised this beautifully in this area, that explains the anomalous findings they were finding during COVID. For example, those patients that had really strong bowel infections with COVID seem to be better off by being vaccinated. So that would fit with, this recall mechanism of systemic immunisation activating the memory cells now in the mucosal immune system. So you see, we do actually try and cover these anomalous resolutions now via these principles. The important point is that the mucosal immune system has similar, it's similar, but it's different to the systemic immune system. There is communication between the two, but the mucosal system, in terms of cellular weight and output of immunoglobulins, that is antibodies, secretory IgA, is 10-fold greater than the systemic immune system in sheer size and weight, probably because it has to confront every day new diseases. So the body's focus is there, and then if they escape and get into the systemic, we have the systemic immune system as the backup. So that's all I will say. That we're trying to give suggestions and guidelines for future generously funded research programs. Really, in our article, that's all we can suggest, I suppose.
Yeah. So there is no current alternative for a parent who might have concerns or misgivings about the existing paediatric vaccination schedule. There's nothing in the pipeline right now that would give them options to say deliver a vaccine via the respiratory route, for example.
Not at the moment.
Back to the chickenpox parties then. So what?
It's certainly better to get it when you're very young than as a teenager or later.
Oh, tell me about it. My kids had chickenpox when they were, 6 and 2. I'd never had chickenpox as a kid. I wasn't vaccinated against it because they didn't have a chickenpox vaccine when I was a kid. I grew up in the 70s. I just didn't have it for some reason. It was strange. All my friends had it. I was jealous because they got to stay home from school for a week and I never did. So I got chickenpox at the age of 30, 35. It was awful. My kids were fine. my kids were absolutely fine. I had a really rough time. So highly recommended. If you're going to get chickenpox, get it as a kid. It bounces straight off you as long as you're well. So let's see.
There are some things you can do to reduce infection rates. Simple hygiene practices. Hand washing, avoidance of crowds, that sort of thing. Don't take your baby to the supermarket. That sort of idea. Clean linen, bed linen.
All the practical things.
We know that the parental bed and the sofa are dangerous places for babies to sleep, because they're contaminated.
Paul, what do you just what you said about not taking your baby to the supermarket? I have a number of friends who are of Greek and Asian or Chinese backgrounds, and they have a custom variously described within the different cultures called lying in, where the mother essentially stays home. And I find this really interesting. Across cultures, it always seems to be the same duration, which is 40 days. So they have a lying-in period of 40 days where the mother stays home. She focuses on the newborn baby. Often her mother or some other female relative will come and stay with the family. They take care of the husband as if he needs taken care of, and the older children or whatever, and cook nourishing meals for the mother and whatever, and let her just focus on the baby. And again, this is explained culturally in a variety of different ways, but it seems to me a pretty darn good way of protecting the baby against lots of potential infections that it could be exposed to if you take the kid off to the local Westfield when they're a week old.
Yeah, allow the baby's immune system to develop. That's right, and mature.
Yes.
The longer you can do that, the better, as far as I can see.
Yeah, agree. Yeah. And of course, the mothers may not have immunity to these advantageous, things in the supermarket. So she's never even given the chance to pass some of that on to her baby through colostrum.
Yes. So, and of course, she's just gone through birth, probably lost a lot of blood. She's in a weakened state herself, and so she may not be able to mount, her usual robust response to infection. Yeah. I meant to ask you both this question early on, but why not? I'll throw it in here. Has the current Australian childhood immunisation schedule, or the adult one for that matter, has it ever been tested for safety and efficacy?
No. I think in a word, no. Yeah. Yeah.
What would adequate testing for let's focus on the safety bit. We'll come to efficacy in a moment. What would adequate safety testing for childhood vaccines individually and the schedule as a whole, what would that look like?
I suppose, strictly speaking, you would have to do a randomized controlled study to get the absolute, fundamental answers. I think some of the studies are all based on adult studies. Looking at adverse event rates and things like that. I don't think
how big would an adequately powered trial have to be? How many, say in the case of a hepatitis B vaccine, how many newborn babies would have to be administered a hepatitis B vaccine? How many would have to be administered a pure placebo, a saline, in order for such a study to be adequately powered? And how long would the follow-up period need to be, in your opinion?
It would have to be in the thousands, probably tens of thousands, really. Considering if SIDS is one case in every 2,000, you're going to have a lot of babies in the trial.
Voluntary consent for the placebo group, I think, would be impossible with a lot of, particularly in the economic world. I think it would be impossible. A mother would say no. Sensible mothers would say no.
Yeah.
So I don't think you can do it, quite frankly. In that sense.
Tricky one, isn't it?
It's real tricky. Yeah.
Yeah. That's pretty concerning. Yeah. And to be honest, I don't know, after the COVID schmozzle, I don't know if you could actually drum up enough parents who'd be willing to enroll their child in a clinical trial of this nature. And I'm sure you're aware of the licensing trials for the two Hep B vaccines that are on the market. One of them had a follow-up period of 4 days and the other 5 days. And if memory serves, they had no more than a couple of hundred participants in either trial. And it was a mixture of, children, teenagers, and again, if I remember rightly, adults and no newborns. So thought passes for safety testing. Awesome. Okay. Let me see. I just want to make sure I've covered all the...
Can I just give you one response to what you've just said?
Go ahead.
Against it, because there's a massive big pharma political complex on vaccines that is simply not going to allow the removal of the vaccines from general use. They're going to constantly advocate, as they did yesterday in the pages of The Australian with the respiratory syncytial virus for the elderly. I read that headline, I couldn't believe it. They need therapies, not vaccines that won't work. And you see, that's the whole point here. I think there's a juggernaut of powerful money vested interests that are simply not going to deviate from the vaccine schedule. That's what we're up against, whether in babies or in adults. It's just extraordinary how powerful that opposition is and how well organised they are. So, yeah, podcast programs like yours are useful to people that want to find out all of these issues that we're discussing. I just hope more and more people, your ear is closer to the ground, Robin, than mine is on this, just from the way you're asking the sort of questions you ask. So maybe we should turn it around. We ask you, what do you think is going on out there in the large population of the concerned population, in the case of SIDS or mothers? What do you think is going on?
I think a lot more parents are feeling, let's just say, emboldened to ask a lot more questions. And I really, prior to COVID, I did have conversations with parents-to-be or new parents from time to time where they would ask me questions about the vaccine schedule, and I would simply answer honestly and point them in the direction of sources for them to follow up. I mean, I don't prescribe, so I don't recommend to people a course of action. I just kind of point them in the direction of resources to help them answer their questions. But those conversations were extremely occasional, and now they are really quite frequent, to the point where if I am seeing a couple intending pregnancy or a mother who's already pregnant, this topic of conversation comes up real soon.
That's right. That's it.
Yeah. It's part of the conversation about medical care on the whole. I would say women are also questioning whether they should be having as many ultrasounds during pregnancy. They're questioning that a hell of a lot more, and I think they should, on the basis of research that I have seen. They're questioning all manner of things. They're questioning the vitamin K shots at birth. So yeah, there's a lot more of this questioning happening. And as I say, I think parents are feeling emboldened about it, whereas in the past they might have had concerns. They might have wondered just why the childhood immunisation schedule was so densely packed, but they didn't really dare to voice questions. And so I think the total disaster of COVID has actually had this silver lining where a lot more people are asking questions. And yeah, I do suspect that has had something to do with the fact that you two and your co-authors were able to get this paper published. And I look back on the history of publication and retraction of publication of all sorts of articles that raised any kinds of questions at all about vaccine safety and efficacy. And we didn't even get to talking about adjuvants, but yeah, there have been papers published about adjuvants, especially the aluminium adjuvants that have passed through the peer review process. They've been published, and then pressure is applied to the publisher, and these studies get retracted. So it seems to me, though, that more of these papers are getting published and staying published. I think that's positive. On the subject of adjuvants, I meant to come back to this, and let's just discuss this topic briefly, because I've already taken up a lot of your time, and thank you for both being generous with your time. Adjuvants, especially alum or aluminium or aluminum for our American friends, aluminium-based adjuvants. What contribution, if any, do these make to SIDS or to neurological problems, or to any of the other types of immune disorders that might occur when a baby is subjected to multiple antigens at once?
I don't know the answer to that. I think we've got enough in terms of the number of antigens to account for the problem, whereas Ted might have some other ideas about adjuvants in addition to the poly antigen.
Well, all I would say is that Paul's right. Just the sheer aggregate of antigens is like an adjuvant itself, because that's the whole point. That's the whole point of the adjuvant. The adjuvant is to try and get the cells of the immune system together, the lymphocytes, the macrophages, the dendritic cells, all the other cells that help get an immune system off the ground, get them together in one place, like at the site of immunisation. It's like a deliberate inflammatory stimulus to initiate an immune response. So that's the whole point of adjuvants. They're accessory to the antigens. But there are developments, as we point out in our paper, of really quite non-powerful antigens that aggregate the antigen in a way that makes it like its own self-adjuvant. So that's the whole principle of adjuvants. It's just that most of them now are aluminium-based. They're salts. And I've actually worked in this area. They're very, very potent adjuvants, they really get cells together. But I noticed there's been some discussion about the doses of aluminium. It's not so much the dose in the immune system, it's the power of getting those aggregates together to get the immune system off the ground. Now, you can imagine if you have a number of these shots all the time, because that's the only difference between the total doses, apart from some exceptions, and all these shots over the first year of life, whether it's 26 or 27, many of them would be adjuvant-based. So that means you're getting repeated shots of the adjuvant as well as the aggregated set of antigens that you just discussed. So, altogether, it's the hyperimmunisation that is the problem here. So, so the adjuvants, to sum up, adjuvants are set up to get immune systems off the ground. So you can have, in a traditional immunology setting, many, many years ago, that's what you do experimentally, to get the thing going. But now that it's being applied willy-nilly to human beings, the consequences of it are not being recognised, it seems to me. Hyperimmunisation is something I wouldn't recommend to anybody. You get the annual flu shots, annual RSV shots, annual this shot. That's something that's.
And now there's the shingles shot as well, and pneumonia shots for older people. Yes. Yeah. Just on that topic of well, I suppose I would colloquialize the role of an adjuvant by saying essentially like it revs up the immune system. If you just dangle the antigen in front of the immune system without the adjuvant, the immune system is going to go like, who cares? Doesn't bother me.
There are good reasons for that, because cells in the immune system communicate with other cells. They can get them all together in the same place. They can communicate energetically and cytokine-wise. So that's the reason why we use adjuvants. But can I just make one comment on your earlier point about the barriers to the mother? Because I wanted to say it when you were both talking. But, the fact that most mothers have got to send their children to, for economic reasons, to childcare centres, and the childcare centre has a policy that they only can take vaccinated babies.
That's right.
That's right. Or to getting them involved in preschool and in school. Now, what an appalling policy. The mother, and most mothers can't afford that economically. So, look, it's a terrible dilemma. No?
Yes. I don't know if
6 years of life.
I don't know if you're aware of the backdrop to that whole no jab, no play, no jab, no pay policy. Yeah. But I happen to. Yeah, I happen to sort of have. I've had quite a few conversations with people who've investigated this, and let's just say those policies were not medically driven. They were economically driven by extremely powerful interests in this country, and I might as well name names because what the hell, the Murdochs. So the no jab, no play, and no jab, no pay policies were effectively ginned up by the Murdoch press, and then pushed on to the government, which was more than happy to take it on. So, that's let's just say it wasn't the well-being of children that prompted that policy.
No, that article yesterday that inflamed my passions, the RSV vaccine. That's in the Australian, and of course that article didn't get reproduced in all the other Murdoch papers across the country on the same day. It's very, very powerful propaganda here. extremely.
Absolutely.
Yeah.
Absolutely. One other thing that I wanted to ask you, sorry, just on the hyperimmunisation front, is the role that hyperimmunisation might play in, for example, generating allergic and autoimmune conditions. Both allergic and autoimmune conditions have absolutely exploded, and in very young people. I think I went about 10, 15 years in clinical practice before I saw my first case of Crohn's disease. And then within a couple of years, honestly, every second person I was seeing seemed to have Crohn's disease. And they were being diagnosed quite young. And they would say, 2 or 3 other people in my class in high school also have Crohn's disease. And that's just one. I mean, then there's all the, the autoimmune arthritises and the psoriasis and the weird and not wonderful at all autoimmune diseases. Any connection between hyperimmunisation and autoimmune disease?
I'll let Paul answer that. He's across that better than me.
I think it's still being worked out. I think there's some pretty good evidence emerging now. With respiratory things like asthma, that seems to be a classic in relation to vaccines. What else, Ted? I can't think.
It's all the whole. Well, that's really the whole point. There's a whole spectrum of things now and that really comes down to the unknowns and the complexity of the immune system, particularly when it gets souped into the Th2, phase. So there's just too many swinging balls out there that we can't. What the interactions are going to be. I think the immune system and the brain, but the immune system and its mobile cells and movement around the body and its mucosal system is so complex. We can't treat it like a simple physics experiment of A causes B causes C. A could cause A, B, C, D, E, F, G, and then all the other components could be interacting with each other. And therefore we get a unique set of symptoms in each patient. My God, there's a whole cocktail of strange symptoms here. That's all I can say on that. I'm just looking at it from the foundational philosophical sense that how can you dissect and tease apart such a complex system like that when you set it in train with hyperimmunisation?
Yeah.
What strikes me also is that our existing pharmacovigilance systems are very, very poorly set up to capture the effects of the vaccine schedule. In that, as you say, you've got complex system nested within complex system nested within complex system. So you've got the immune system of each individual, which this was in your paper. I meant to highlight this, but one of the important points that you made in your paper was the intense genetic individuality, or to put it another way, the unbelievable degree of genetic variation between different people, and how this shapes their immune response, I'm guessing both to infection but also to vaccines. So you've got that degree of complexity, the individual immune system. That immune system sits within the complex system of the entire being, who sits within the complex system of their socioeconomic milieu. And then you come along with your magic potion and say, we're going to fix infection. Like, good luck with that.
Look, can I just correct the typo that was in our paper on that point? When I said when we gave a number on the individuality, the probability of apart from twins, probability of identical genetic systems in all human beings is 10 to the 400. Actually, the typo was they had 100. I noticed it just slipped through correction. Paul, it's 100 to 400. No, it's 10 to 400. 10 to 400 is a massive astronomical number. But
too many zeros, man. Yeah, like you can't even. The human mind cannot even grapple with numbers.
We can't assume. That's why you get this plethora, I think, of strange sets of symptoms to, a multiple, insult system like hyperimmunisation. Every imaginable outcome is probably being, you can't assume that one size is going to fit all. But all vaccination programs make that fundamental assumption in a way, and then let's worry about the adverse effects later. When in actual fact,
the problem with getting information on adverse events, it's a passive system.
Yes.
It's not active. It's not targeted.
Yeah, good point.
Are you both familiar? You both familiar with the paper that was produced? RFK Jr. refers to it frequently. It was written by Lazarus and co-authors, where they developed essentially, an early AI model, like a machine counting system, to be applied to the Harvard Pilgrim HMO Health Maintenance Organization, which covered, I don't know how many, tens or hundreds of thousands of people, but a lot. Okay. And so what they found is that adverse, like when they tallied up, essentially what the system did was, when someone say took their child in for medical care within this HMO network, the system logged the reason, the billing codes for why they attended, and then correlated that to the vaccines that they had received. And essentially the system surmised that less than 1% of adverse reactions to vaccines were being reported. So the system calculated that all of these different, pathologies were actually attributable to vaccines. And then the CDC had actually commissioned this work, and the authors of the study said, "Hey, we tested it out. It seems to work really well. Do you want us to take it to the next phase?" And they never heard back.
Yeah, well,
Wow.
Yeah, and so these passive systems that rely on a doctor noticing, this child has developed asthma. This possibly could be, I don't know, but it might be a reaction to the vaccine that I administered a month ago, 2 months ago, 3 months ago. And obviously the whole purpose of a pharmacovigilance system is that the doctor doesn't have to be sure that the medication caused the effect. The doctor is just supposed to report, patient had this medication, patient developed that symptom. I don't know what to make of it. I'm filing the report. It's your job. It's your job, keeper of the pharmacovigilance system, to figure this out. But they don't report. And that's usually because they don't recognise that these symptoms could be adverse reactions to vaccines. So we simply don't know. All right. Once again, I want to thank you both for your generosity with your time. Is there anything that I missed? Is there anything that you wanted to discuss about the paper which I haven't covered already?
Can't think of anything. No.
Don't either.
Okay.
You've done a good job, Robin. Thank you.
So final thoughts, and I'm going to put you both on the spot. If you had, let's just say, adult children who were having grandkids, and they came to you and they said, "Dad, what do you think we should do about these vaccines? Should we get our kid vaccinated according to the Australian immunisation schedule?" What would you say?
Well, I can tell you, I've been exactly in that situation of one of my sons, and they're proposing to have children. I just bring them gently to the attention of all the information I know, and they know exactly where I stand on it. That's all I can do. But it's a real thicket. That's why I raised the childcare issue before in the early preschool. The fact that they've got to tick those boxes just to get their kid looked after so they can continue to work is another major obstacle. That's all. I just give them the truth as I see it. That's all I do.
It's interesting because my eldest son saw Ted's initial video online setting out the problems of the COVID vaccine. And my son contacted me and asked me, "What do you think of this guy's video?" So I had a look at it and I said, "Well, it seems extremely plausible to me." And I thought, well, it's your decision. You'll have to, I can't make that for you, whether you want to get vaccinated or your family vaccinated. That's up to you. But because it was highly plausible, I thought I'd be thinking about not getting vaccinated.
Well, thanks for that, Paul. It's good to know. I really get feedback like that. It's good to know that.
Good.
Well, like you said before, the general response seems to be, we don't talk about it among your colleagues. I mean, we can't actually mount a decent, rational argument, so we just won't say anything.
It's hard, isn't it?
All right. Thank you once again for the effort that you put into writing this paper. Looking forward to reading your follow-ups when you publish them. And is there? I don't imagine either of you have like a big Twitter following or you're on TikTok or whatever. But if people did want to, if people wanted to sort of follow you, are you on any kind of social media platform? You don't do TikTok, Ted? I'm shocked.
I'm not on any social media, but I do have.
I can't stand it.
No. Our generation have done by all this. I mean, I find it just clutters my brain. And confuses me. And but look, but all of my papers, I've made sure they get up at a place called the site is on academia.edu, and the site is called independent.academia / Edward J. Steele. That's why I just make sure all my papers.
Well, I'll put a link to it in the show notes, Ted. So there you are, folks. Don't go on Twitter or TikTok or Instagram to follow Ted or Paul, but you can find Ted on academia.edu. Excellent. All right. I've thoroughly enjoyed this conversation, and I really hope it'll get a conversation going among my readers and subscribers. So thank you once again.
Thank you, Robin.